Hello, this is Len Krause from AE and Associates. I'm calling this a better way to CDI, capitalizing upon the opportunity. And I have Dr. Ben Kartchner. He's a regional associate medical director, care manager in the multi-care health systems. Dr. Kartchner, thanks for being on the podcast. If you can go ahead and kind of give us a background and what you're doing now, this would be much appreciated.
Sure. Thanks, Glenn. I really appreciate you having me on the podcast today. So I'm a family medicine trained, but I've never really done anything other than hospital medicine. And I had a little schizophrenic, career in terms of my decisions. I spent a year in residency in surgery out in the Boston area, and then did actually partial year of anesthesia, and then I had a medical problem. I had to take some time off for a while, and then came back and did another family medicine residency. So I done quite a bit of residency. Once I finally figured out what I was going to do, I became a hospitalist, and then moved out to where I live now in Coeur d'Alene, Idaho, which is for a lot of people probably don't know where that is. It's actually a vacation town up in North Idaho, right across the border from Washington, in Spokane, Washington. I've been a hospitalist for about 10 years, and started doing physician advising actually at the hospital in here in Coeur d'Alene about 5 years ago, and then was hired by Multicare, who owns two of the hospitals over in Spokane, and to be a medical director over there covering utilization management. And now I've kind of shifted more to where I do care management stuff, but I also help out with CDI. So I still practice. I just cut down from half time to quarter time now. And so I still do clinical work a little bit when I can to try to help out. And then I'm a member of the board of directors for the American College of Physician Advisors, in charge of their TLC, the Learning Center. So do a lot of their education and CME stuff. And then let's see what else. The big thing. I guess I was the recipient of the ABCRP, the Board of Quality Assurance Utilization Review Physicians, what do they call it? The Diplomat of the Year award back in 2020.
No, really? That's great. I didn't realize that. That's something to be real proud of.
Yeah, it was something that it was a really great project we did with COVID. It was COVID drop teams, and a lot of people had drop teams. We kind of, there could be an entire podcast about this, but we kind of shifted that model to where we partnered with the Department of Health and became a preventative force instead of really kind of a treatment force, which was really effective. And so, the group won the Washington State Hospital Association Community Leadership Award for the year of 2020. And then I submitted for the APP report too. So I kind of helped run a lot of that project back in 2020. So it was a little bit of a shift from the physician advising stuff, but that's why I'm more involved with care management now. But in addition to CDI when I can.
Well, quite an extensive background. Good to hear it. So let's just jump right in. So as a physician advisor, you have a strong understanding of CDI programs. I think that's why we connected on LinkedIn. And the efforts to enhance integrity of the medical record. In your mind, are current CDI programs successful in driving real, measurable, meaningful, sustainable improvement in medical record documentation? Want to get your thoughts, because obviously you're practicing, even though you're just quarter time, you're still practicing. And you just told me that you're going to be doing some, right after the podcast, jumping into doing some appeal letters. So I want to get your thoughts on that.
Yeah, and I think the short and long answer of that is yes and no. So I think there are things the current model does well. And when I say current model, I think you and I both agree that the current model is query based.
That's right.
CDI programs. And so there's some things they'll do well. But the things they do well are that they questionably they make the codes more accurate. And when I say
Right.
codes, I intend to use that word specifically, codes, because it's not the documentation, meaning we're
Yep.
capturing codes, which then by somewhat of a trickle effect, you can have, improved quality scores and things like that. So it also improves and helps for more accurate reimbursement. But it improves the physician documentation by negative interactions. Generally, it's the stick and really not the carrot, meaning that it becomes an add-on thing where a query is sent and you answer the query to make it go away, and kind of that's where it stops. There's probably some others, but the high, there's the high points I kind of wrote down before. So what the query-based models don't do well, though, is that what I alluded to before is they don't actually improve the documentation. They improve the ability to capture the codes that lead to higher reimbursement and higher metrics, which kind of trickles down into quality and things like that. But they don't actually improve the documentation itself. And the second part of it is they run the risk of physician and provider burnout. Like you mentioned, as an active hospitalist, I think that the best way to look at this, I promised I'd make I'm a Office Space fan, the movie, and so every time I'm on, I do a presentation, I bring some Office Space joke. But
Yes,
so
that's good.
if your listeners are into Office Space, will understand this. And so back when the protagonist in Office Space was being interviewed by the Bobs, and the Bobs were the consultants that came in, he said that, well, there's a comment in there. He said, well, what I do is the bare minimum to make things go away, meaning I have 5 different bosses who come to send things to me about TPS reports constantly. And so I do whatever is the bare minimum to just not get yelled at, to just not get in trouble. And I think our current CDI programs are a lot like that, in the sense that you learn enough to maybe document the acuity of the congestive heart failure, or maybe you learn a little bit about type 2 versus type 1 MIs, and
Right.
and some sepsis stuff, but you do that to make the queries go away and not really to improve the documentation. And the second part, another part, is they don't improve the documentation to support medical necessity. Handoffs, communications with other disciplines, it really doesn't do anything to move that needle. And there's a lot of opportunity there, I think, with documentation when it comes to improving the length of stay, the throughput, the medical necessity, the utilization management part of things, beyond just when we talk about CDI. So that's kind of my feelings about the current state of things.
And I'd like to make a comment or add to what you said about medical necessity. Dr. John Zellum is a longtime colleague of mine, has a company down in Florida, and has been a physician advisor for years. He says it very eloquently. Without medical necessity, there simply is no need for CDI. And in fact, I'm doing a presentation as part of my Top Gun CDI goals on next Thursday, and I'm just working on some slides for medical necessity and how CDI can really help physicians improve that communication of their thoughts to demonstrate medical necessity for the admission. So I agree that the biggest area of opportunity ripe for improvement is working with physicians to help them report the medical necessity. If you think about, I think you probably would agree with this statement. If payers judge medical necessity based on screening criteria in conjunction with the medical record documentation. So if we don't have a good patient story depicted and told, starting with the HPI and chief complaint, as a sort of a building block in the H&P to the assessment and plan, all the diagnosis in the world doesn't matter. All the increases in case mix, which kind of leads me to my second area of focus here. What do you think is holding back programs? I've been in CDI, not to brag or anything. That's not my intention, but I've been in CDI from starting in 1995. Even before it was recognized as a profession, and basically nothing's changed since the official, to me, CDI officially started when the ACTIS was came into being with the MSDRGs 2007 and 8, right?
Right.
But what is holding the CDI programs back from achieving really integrity in the medical record? We changed our name from clinical documentation improvement to integrity, right? And what is holding us back? And the second part is, how can CDI proactively address these shortcomings?
Well, I'm going to, I
that we
100%
just
agree
talked
with what you
about,
said about,
or what I refer to as opportunities.
yeah. I have 100% agree with what what you said, and I think there's several things that are holding back CDI programs, and so I think that and I'll be honest, I think we're moving in the wrong direction with time and not in the right direction. The pandemic set us back quite
Absolutely.
a bit.
Mm-hmm.
I know in our institution, we at least had the CDISs were in the hospital. Prior to the pandemic, they I don't want to get ahead of myself, but now work from home is kind of it's the standard. It's and they've all moved to remote. And the second part is financial strains put on the hospitals because of the pandemic. Hospitals are a lot of them are losing money. Some are some people are making money hand over fist, and others are trying to stay alive based upon the thin margins in the hospital.
That's right.
Has really shifted to where we move into that query pattern because again, CDI programs oftentimes, and I know ours does, it rolls up under the finance people, and so when things get thin, we move to the basic tenets of what's going to make us money, and really the queries and increasing the CCs and MCCs is what does that, which then leads to work from home and some other things, and so we become stagnant, and so part of the problem with that is that when we want to change the documentation of physicians, we need to develop a trust with the people that are working with it. And having somebody through a computer system send a query every once in a while doesn't really, develop that trust with the physician. And so in my opinion, we need to have some kind of CDI presence in the hospital. I'm not saying all CDISs need to come back, but there needs to be something. And so, I think having a physician advisor in the hospital, to help these overworked staff that are basically burning out because of query fatigue and all sorts of other stuff. Help them to not just get by and answer queries, but to actually improve their documentation. They need to be shown that there's an ROI for them, meaning it's not just like, hey, here's another added task. Here's something we can do to actually help you become more efficient. And that's all through the documentation. So you really need to hire physician advisors, but doctors are expensive. But the reality, the bottom line is, Glenn, I have trouble believing that over a long period of time, doctors are going to get the message and change if the message is not presented by at least somebody who is their colleague, meaning another physician. So. And then we move into what you were talking about before, where you need to have partnership with other departments. The silos that exist, are really counterproductive. Both our and our CDI roll up through finance, but they're completely separate departments. And so, how do you cross those two together to where you can partner with CDI to help improve the documentation for medical necessity, particularly when and not just medical necessity, but also with quality. We need to present the information to the doctors so that they can see it does benefit them, meaning like, hey, surgeon, if you document, if we can teach you about PSIs, we can teach you about complications. When patients go to look at your CMS stuff, they will recognize that you don't have a bad quality score. You don't have these negative things, and it all comes down from documentation. But that needs front-facing physicians and people who are going to teach the surgeons about that and teach them in small little, possibly at the elbow, on rounds type situations, because nobody wants another meeting where you sit there with a PowerPoint and kind of go over things again. They're too busy for that. And they're too busy for the queries, and so they shut down and they don't recognize that, hey, some of this documentation stuff actually does pertain to you, because your patients can go look at your scores, on CMS.gov and see how many complications you have. And that's really an untapped area of physician engagement, in my opinion. At one point in my organization, I started making a monthly dashboard that I would present at all the IDT meetings, and it had the hospital mortality. It had length of stay. It had a bunch of other stuff. I'm trying to remember what it was, and it kind of fell away because I moved into a different position. But the goal there was to get that information in front of the physicians to get them interested, like, hey, this does pertain to me. And what this guy is telling me, this physician advisor is telling me, actually can benefit me in the long run. And then also partnerships with case management. When physicians document why the patient needs to be in the hospital and the care couldn't be provided as outpatient, and then what needs to get done to get the patient out of the hospital, that results in a cascade of information to case management, to nursing. It puts everybody on the same page to where we're all working towards the same goal and reduces delays. And we've actually done that in our. That's something along with the medical director of the hospitals we've done. We've added a piece of documentation at the bottom down where most hospitals write the DVT prophylaxis and code status and things. We've put a line down there where I tell the physicians, I want you in one sentence to tell me why this patient can't be discharged today, and then what needs to be done to get them out of the hospital. And that one sentence right there is basically you're asking them to define the medical necessity of all the stuff you talked about above, but define the medical necessity for why the patient can't be discharged. Are they on, their oxygenation is unstable, I need to see them tomorrow, whatever it is. But by putting that one line in there, that becomes to where on a daily basis you have one, a line that can be used in a peer-to-peer, on a denial or whatever else, that says, hey, this is why this patient's still here. It's not safe to send them home. But B, the nurses can go look at that and say, oh, okay, here's what I need to do to get this patient out. Or case management knows, okay, hey, this is what needs to be done. It lines everybody up together. So, and that's all related to the documentation. And that's just a small part, I think, of improving the overall documentation. But that's where we started, is by saying, hey, just add one line for us.
And I think that's great, because Dr. Jake Martin, who I work with, we've been working with him for almost 27 years now. He and I agree that every progress note should end, just like you say, with a statement of medical necessity. Why is this patient not going home? You certainly, to me, hit the nail on the head, because when I was with a teaching hospital in the Southwest, breaking down barriers between case management, UR, and CDI, we're all looking at the same chart, but for a different reason. So why not work together? So it really was a much more efficient way. And we're not actually, the physician is not getting queries from 3 different groups on the same day: case management, CDI, and UR. Why not have a conversation with the physician to the extent that the documentation helps all parties? I agree with that.
And have that, in my opinion, have that conversation during multidisciplinary rounds in the morning. If we're going to take the time for the docs, and we've struggled with this, you're going to force the docs to attend these multidisciplinary rounds. Let's make them useful to where they can use that time, because otherwise, as a hospitalist, I'm done and I can go home when my work's done. Meaning that, so for an hour, if I sit there and do multidisciplinary rounds, that means that's an hour that I can't see patients.
That's right. That's right. That's absolutely right.
And so it's extending my day. And so my thing is, well, let's make it useful. Let's bring everybody to the same time so we can knock all these queries, all this discussion about medical.
That's right.
That's can be done right there.
That's exactly what we did. We had multidisciplinary rounds 4 days a week, and each CDI person was assigned, for the entire week. And if we had individual queries, or we want some teaching points that we wanted to make with the query, because queries is not a teaching tool whatsoever, physicians really loved it, because they don't want queries. They want to show me how to avoid them. And if I was a physician, because I was thinking about becoming a physician, but I was 40 years old, and my father didn't want to pay for a third education, so there went my finances. But the situation really is, how can we make physicians' lives more much better, so they can work efficiently? Dr. Cutler says, work smarter, not harder. So I really believe that there's as you said, there's so many opportunities that we can really take advantage of, which leads me to kind of my third area here. I think you touched base a little bit on this already. In an ideal world, how should CDI reinvent it? Because I really believe, and a lot of my colleagues and physicians who I work with believe, that CDI should reinvent itself. I think you touched on a great point. We've kind of gone down the wrong path, as you mentioned. And how can we become allies or resources or mentors or guides? Because I think you certainly hit on one point. trying to cram all the information in these 1 hour long presentations. Physicians turn off in about 10 minutes. So how can we kind of reinvent ourselves and create a vision that inspires physicians? When they see CDI coming, generally speaking, they run as fast as they can away.
Yeah. Well, I think, so CDI programs aren't going to go away. So those are already in place. And so I'd say the first step is to find physician champions at each location. If you look at the ACPA, one of the criteria for a physician advisor is generally you find somebody who the staff respects, they like, they, can communicate well with. And that's for this exact reason, because when you find that physician champion or physician advisor in the hospital, they become a resource instead of, it goes back to what I said before, that it's not a carrot even, it's a resource instead of a stick. And so in my opinion, you should really have one per hospital. Now, if your hospital's too small, then you can combine and have a physician advisor for who's also working medical necessity from the utilization management side, also work with CDI, and have a PA cover, both those areas in one small hospital. And that was, what I won't go into my story too much. That's what I tried to do initially, when I was a physician advisor, early on with multicare. So I think that, when you become a resource, somebody that, oh, hey, I've got a problem here with this, I wonder what I can do, and I know that physician advisor's phone number, or I know where they are, and I can call them and they say, oh yeah, here's how you fix it. Or they come down and they actually, can be on rounds and help you out. That creates a value add for the physicians instead of a something that's detracting, like we talked about before. And so you need to have an escalation pathway, with somebody that the medical staff knows and trusts, so that when questions come up, when queries come up, when things that they don't understand come up and they want to understand it, why it's happening, we need to have somebody who's there that can actually, answer and respond. Not somebody, and some organizations do it well, where the CDIS is, they know the physician quite well and they actually interact and they're reachable. But, in a lot of places, I don't even know where they are there. I think they're from home. I don't know what the phone number is. And so if I get a query, then I'm like, I don't know what to do with this. Who do I call to help answer those questions? And it goes back to that person who we designate, whether it's, in my opinion, it should be a physician advisor, needs to help. And in my notes, I put help as capital letters. They need to help the docs as much as they carry the stick, so to speak. And so, and then beyond that, I think that ideally CDIS would be in the hospital, present on floors during rounds, things like that. But, I don't think that's really going to, a lot of places aren't going to change that. I don't think that's going to happen. But if that's not going to happen, well, then we need to have a way to where we can escalate, like I mentioned before. So I think we have a great opportunity right now, actually, that is kind of untapped. The inpatient E&M codes changed.
I'm just going to say that. I was going to ask you to put my final question on that.
And so, they just changed. And so the docs are kind of like, well, I don't know what to do with this. And we all know that doctors, whether it's right or wrong, they care about how they get paid more than sometimes how the hospital gets. But well, we've got a marriage, right? An opportunity to marry those two things together. And so with the new E&M codes, we could actually, have CDI working with the physicians to change their templates, those the damn templates that cause problems all the time with stuff. Well, we have an opportunity to intervene and actually change those templates right now, to be involved with changing the templates and putting them into ways that are not only useful for the CDI people to capture things, but also useful for the physicians. And in that partnership, when we're helping them out, we create relationships, and we know that relationships are what moves the needle long term.
Absolutely.
And then the third thing I put is, in CDI, we talked about this a bunch, but they need to be married at the hip, really. And that's how I put denials can be broken down into 3 categories. And so I put, the 3 categories are: the insurance company is right and there wasn't medical necessity. Right. Option 2 is the insurance company is wrong, but the documentation stinks in showing the medical necessity. Or the third option plan is it's an MA plan. And I made that as a joke, where the MA plans don't care, they just deny everything. So the third takes up
it's not a joke, unfortunately, that's the truth.
Yeah, it's kind of it's a sad joke, I guess. And that takes up all too much of what there is. But by the collaboration of and CDI in supporting having having the documentation to support the medical necessity for, for daily visits. And I know, most of our Medicare payers pay DRGs, but a lot of our Medicaid are daily rates. And so, their medical directors are scrubbing that chart. And the second they find that there's not something in there that for which the patient needs to be in the hospital, bam, it's downgraded immediately. And so that daily medical necessity, helps with reduction of denials, but it also helps with all the stuff I talked about, earlier with the communication and throughput and length of stay.
Boy, you're, like I said earlier, Dr. Kartchner, you're a breath of fresh air, because and I truly mean it, because without UM and CDI or UR working together, we're almost going down a separate path. It reminds me of, you said you lived in Boston. Well, I lived in Boston for 10 years and went to Northeastern for a couple of years. And I always liked to watch this, the skull races over there in the Charles.
Oh yeah.
Yeah. And if someone in the boat is not precise with the same, right down to the 10th of a second, putting oar in the water, okay, they may lose the race. It's the same thing with CDI. When we're not in sync with the case management and UR, they're kind of at a loss sometimes to call in for additional days because the documentation is woefully inadequate. So we found, or at least our department, our UR found, hey, working together is a symbiotic approach. If they found something that didn't quite pass muster from calling in for additional days, they didn't want to waste their time knowing they're going to get a denial. Why not pick up the phone, page CDI? You see us on the floor, say, could you look at this and get back to me? I have to call it in before noontime.
Absolutely.
It was, and now that I'm not there any longer and the program went back to strict CMI, CC, MCC, I'm getting notes about once, twice a month. Hey, when you coming back? I say not anytime soon, because Las Vegas and heat, it doesn't work too good with me. I don't like 126-degree temperature. I don't care if it's a dry heat or a humid heat like in Florida. It's 126 degrees. I couldn't stand it. So
yeah, that's too hot.
And the last thing I want to just reinforce before we close here is that I agree that if you want to have an effective CDI program with trust and respect and really help that physician work smarter, not harder, you have to be on the floor and make yourself available. Oftentimes I found that our people would not be on the floor when we first started. No questions from physicians. When we're on the floor, they would say, hey, can you look at this chart? I know case management is going to say it's an observation, but I put everything I know that I think would be helpful in demonstrating the need for inpatient. You don't get that from queries.
Right. Yep. It's a one-way. Queries are a one-way communication. It's like it's trying to, talk through a CB radio or something like that. They just don't, there's no, there's no relationship building, but B, you don't get any education.
Nope.
You basically do what you do to get the query to go away, and then you move on.
And the third thing is it doesn't change physicians' behavior. Why are we still asking for the type and acuity and chronicity of heart failure when the code's been around for 12 years?
Right.
That's our number one query in most hospitals. Doctor, can you tell me what type of heart failure? It's like if I was a physician, I'd be pulling a little bit of hair I have left on my head. Thank you so much for your insight. Any closing remarks for our audience?
No, I think, I'll just say that I think that case management split, it used to be, I don't want to give too much history with this. It used to be that, the UM and case management were combined, and then, CDI came along, and then they broke into this, the case management split into this three-legged stool with social work, case management. And so, I don't think we're going to reverse that, but we need to create some type of communication lines along there, because it doesn't help when when, like, just like you mentioned, when we get all the queries answered, but yet the case gets denied, and so it's paid on ob stay anyway. It doesn't matter how many codes you got in there if we don't get the medical necessity. And then the downstream of that is, if you can reduce denials, how much time and money do we spend, and physician hours do we spend on denials that may be unnecessary? And so all that money could be reinvested up front into that collaboration between those groups to try to prevent a lot of this stuff, and really change the documentation for the better, and also improve the morale of the frontline workers who are burning out, because they're tired. I know that. I see them, and the last thing they need is another query thing coming in here and there. They need to be able to focus on patient care, document concisely and accurately, and kind of move on with their day, and do what they do best, which is taking care of patients.
Absolutely. So thank you so much, Dr. Kartchner, and folks, keep up the good work.